Are you listening me, Leo?
Yes, I am.
Okay, perfect. It's my pleasure to introduce Professor Leonardo Bastos. Leo is a statistician, it's so hard to say this word, by training, with a bachelor degree from Universidade Federal de Minas Gerais, a master's degree in statistics from Universidade Federal do Rio de Janeiro, and a PhD in statistics from the University of Sheffield in the UK. After that, Leo was a postdoc researcher at the London School of Hygiene and Tropical Medicine in the UK, and currently Leo is a researcher in public health of Fiocruz, in the Programa de Computação Científica, Scientific Program, Scientific Computing Program at the Fundação Oswaldo Cruz. For those who don't know, who are not Brazilians, Fundação Oswaldo Cruz is a Brazilian national scientific institution for research and development of biological sciences with many units around the country. And the one where Leo is the one in Rio de Janeiro. Leo's main research line is developing statistical methods focused on epidemiology and infectious diseases, working especially with applied Bayesian statistics, inference in hard-to-reach populations, and real-time analysis for epidemiological surveillance, in special how to deal and remove effects such as delays when facing an outbreak. So very important in the time we live, right? So thank you so much, Leo, for accepting our invitation, and please, guys, help me to welcome Professor Leo. You are no, you're not muted.
Okay, cool. Yeah. Thank you very much, Flavio. Thank you. It's nice talking to you guys. Well, as Flavio said, I'm a peer statistician.
Just a second, we are going to increase the volume because it's very low. We are not listening you very well.
Is it? Oh, I'm sorry. So just keep talking, then you can
they are trying. They are trying.
Control the volume, and then I'll keep talking here.
Is your microphone loud? Do you have any other?
Yeah. Oh, it's just a normal one.
A normal one?
This one. Yeah.
Oh, can we try this one? Where is that?
Não, tá o certo.
Well, it's a speaker problem or I don't know.
Só se falar para todo mundo entrar no Zoom. Não, mas...
Just a second, Leo. It's so low, so low. Can we try this? Changing this?
Essa situação que não faz diferença.
Não?
Não, ó. Só para...
Não faz isso não, Gui.
Não, só para testar.
Não. É melhor não. Maybe ask them to enter Zoom?
Pode ser.
Yeah. Okay, Leo, I think you are allowed to start.
Okay, cool. All right. Thank you very much, Flavio, for the invitation. And well, as I said, as you notice, I'm a pure statistician. I did all my undergrad and postgraduate for education in stats. And then I did, well, a postdoc in the infectious disease epidemiology. Well, just to say I did something on health, but I was already a Fiocruz researcher, so it's kind of... so, yeah, and then working at Fiocruz, I've been dealing with several different public health problems, and well, the one I'm going to talk about today is related to delay. It's notification delay, and why is this important? Why is this a problem? And how to fix it. So, and this delay is basically in the context of infectious disease data. So I'm going to talk about not only COVID, but also talk about dengue fever. And well, this is the data. This is 2012 data. and dengue fever in Rio de Janeiro. I'm not sure if everyone is familiar with dengue. Now I just realized that I could have a slide talking about dengue, but dengue is a disease transmitted by a mosquito. Well, it's a virus disease, an arbovirus. And the virus is transmitted by a mosquito that infected the person, and the person gets sick, and this disease can lead to death. But well, basically you got fever, joint pain, headaches, and it lasts for 1 or 2 weeks. So it's not a nice disease, but yeah, and it's a common problem. It's endemic here in Rio. It's actually what's called hyper-endemic. So it happens every year, but some years we have these big, massive epidemics. And well, massive now is different because now since we had COVID changes everything. And this is the data we got. So when let's suppose we are in the 15th epidemic week in 2012. So let's travel back in time. So we are there in April. And if you look at the data in April, we would see the red line here. So like, well, we had this epidemic here in 2011. And then, well, if we just look at the data we get at that moment, you'd see, well, the curve is going down. So probably the epidemic is fading. So we are not seeing well, we are not seeing an increase anymore. But actually, couple of months later, when you actually look at the data, this is actually what happened. So we faced an epidemic even worse than the one before and the year before. And these observations here, we didn't see at that time because there is delay. So the data arrived later into the system. And well, what causes a delay? Well, there are several reasons for this happen. So it's not this case, but well, we could have laboratory time, well, it usually when the disease is identified, it's filled by hand by a doctor, and then someone must type that into the system. But also after typing that into the system, it took some time for people checking if there is, well, if the data was typed twice and if there's some corrections to do it. And it takes some time to actually the data become available. Or you may also have some infrastructure problems, some health places, they may not have internet. Or they may not even have a laptop or something like that. So, and basically is the delay is part of the game and we have to deal with it. And so for dengue, like most of the cases, like less than, well, 50% of the cases are typed in 2 weeks. So we have also 50% of the cases that are not typed in 2 weeks. And well, 75% is typed in 4 weeks, which means that 25% are not typed in 4 weeks. And also 10% of the cases are not not in the system 9 weeks later. So there is an important delay component there in the data. Dengue, when a dengue case is identified, it must be notified. But well, in the Brazilian law, this case must be reported up to 7 days. So even the system allows some delay. So up to 7 days, so that's at least a week. So it's not necessarily as quick as we'd like to see it. There are some other diseases that this time is really reduced. Like if you have, I forgot the name in English now. It's if there are some diseases that they must be notified in less than 24 hours, like well, some very severe diseases or very lethal diseases. So, well, I'm going to talk also about SARI. SARI means Severe Acute Respiratory Illness, which is a set of symptoms, which is called a syndrome. So actually the acronym is Severe Acute Respiratory Syndrome, but SARS is already a disease name. And SARI is a set of systems for someone who is hospitalized or dead with these symptoms. If the person has fever, cough or sore throat, dyspnea, O2 saturation less than 95%, or any respiratory discomfort. So if you have these three things, the person is notified. And while here in Brazil, this notification is compulsory. So let me just see if it's, yeah. So the notification is compulsory and is part of influenza surveillance, where each person that is notified, the person is also need to have a swab sample, and this sample is tested for some virus. Well, mainly influenza before 2019, and influenza, but there are some other viruses that are tested as well. And well, once COVID arrived, they just add the SARS-CoV-2 into the system, and they tested everything. So that's why the Brazilian data for COVID, severe cases of COVID, is relatively good because it came from a system that was already implemented since 2014. So we had plenty of experience with this data. And well, but once COVID arrived, we had lack of tests, even, and especially in the beginning. So like here, I'm talking about the 25th week of 2020. So it's in the beginning. This is about June or something. Yeah, I think it's June. So it's middle 2020. And I just brought this city for two reasons. Like, well, first one is I'm born there. I was born there, so well, very biased. But the second one is this city this city implemented the closest thing that we had for lockdown. It was not a lockdown, but they have a stronger way to, well, they had some stronger measures than other cities in Brazil. And this was, well, this can be seen in data. So when you see the hospitalizations for SARI, we see that there is this flat component, whereas some other cities, this curve goes up here. Like in Rio, this goes up really high in the first months, but in Belo Horizonte, it didn't. So this increasing number of cases they didn't went up in the first months of the epidemic. So they really did a relatively good job. But obviously, everyone was kind of keen to, wow, we need to reopen the business, we need to reopen everything. So this is what happened in June. So if you look at the data at week 25, this is what we would see. And well, if someone was taking decisions based on this data, would say, well, the number of cases are reducing. So, well, that's good. So it's a good time to reopen. Well, it's 2020. This thing didn't happen. And obviously there was something going on, and this thing is delayed. So, well, on the week 25, this is what we see. So in the other weeks, on week 26, week 27, week 20, up to week 35, actually, when they reopened the business there, the number of cases increases, though the number of hospitalized cases increases considerably. It was actually a three time fold, so it's actually 3 times the baseline they had here, which is really good, which is really bad actually, not good. It's like, well, And well, there are some politicians that are they still keep using this sort of data here to say, well, the pandemics doesn't exist, the pandemics is going down, but well, this is what actually happened. And what we want to do. So let's suppose that today is June 2020. And well, using this data, we want to estimate something like this. We want to estimate the cases that occur but haven't been reported yet. This is what we want to do. And well, we obviously want to check if we got it right. And well, this is actually a true estimate. We did estimate this thing. And well, in SARI cases here in Brazil, basically in 2020 are COVID cases. Well, the number of SARI cases increases a lot, and they are mainly COVID cases. We didn't need the lab confirmation, even though when we had the lab confirmation, we just confirmed that most of those cases were COVID cases. Well, how can we do that? So we need to learn about the delay. So there are two ways to learn about the delays. So the second one is basically taking this time series. So if I take the difference between these two time series, like this, the red one is the week 25, the orange one is week 26. So if I took this difference, I know how many cases arrived, what were typed in 1 week delay. And I know how many cases between this one and the red one, I know how many cases were typed in 2 weeks delay. And I can calculate this for each time, and I can calculate the number of cases that were, well, I can calculate this, how many cases were typed, and I know the delay and when, and I can build a matrix. I show the matrix like that. And also, some data sets, they also have when the data was typed. There is a column there saying, well, the data was typed in 20th of June or 30th of June. And if you have this recording date and I have an event date, which could be the symptoms onset, so which would be the closest to the infection date, which we don't have. But if I have these symptoms onset and I record in date, I can calculate individually the delay. So this is what I'm calling direct approach. The indirect approach would be the difference among several time series. And well, we can do that. It can be done. So, well, this is the sort of data we have. So like this data here, this table here, we have the symptoms onset date, the date when the case was identified, the date when the case was typed, which is not necessarily the same. Like for instance, this person here, the case was identified on 7th of January, but it was typed on the 8th, and the first symptoms were 3 of January. So, and some others were identified and typed at the same day. And so we can calculate for each person the delay. And the Brazilian data, luckily, will have this structure here. But if we don't, but we manage to save when the data set was, when the data became available, we can actually have this several time series here and build the delay and calculate the delay. And well, the Brazilian data for COVID, it was released every Wednesday. So you can do these things. Yeah. And some other countries like, well, UK, they have this very they are very methodic. So they save a new data set every day at 5 p.m. I don't remember, but I think it's 5 p.m. So every day they go there and put a new data set. So you can build this sort of thing. Why I need that? Because, well, I need to define this NTD here, which is the number of cases, notified cases at time t, typed d weeks delay. So I can have this NTD here. And well, if I sum this NTD over d, I can get actually the number of cases notified at week t. It could be not only notified, it could be the first symptoms here. And basically, I can build this matrix here. And this is a key one, so that this matrix is important. This is the one I'm interested. The number of cases at time 1, time 2, time 3, time t minus capital D. Number of cases that happens today. Let's suppose that t is today. Number of cases tomorrow, day after tomorrow, and well, and then the cases here in red are forecasts. So, and the cases in blue are all cases I can observe that week t. So in week t, I know how many cases were typed into the system without delay. But I don't know how many cases were typed into the system with 1 week delay because I'm only see them next week. So this gray triangle here are those cases that occur but haven't been reported yet. So here, like, well, for instance, like this one here, well, I don't know, this one is like the number of cases that have happened this week, but will be typed into the system in D weeks. So like just a couple of, well, in 2 months time, the number of cases that happen today will be typed into the system. And we can learn, well, but we know, well, for last week, for instance, I know how many cases had 1 week delay because are those that entered this week. And then I can learn all this, well, I can get all this matrix here, all this triangle plus this rectangle here. And well, these things are those that I observe, and then I just need to estimate those guys. And how do I estimate them? Well, I can also do forecasts as well. How do I estimate? Well, I just need to set a model. So that's a statistical model. NTD is number of cases. So it's a number of cases. Could be a Poisson model, a negative binomial. Actually, a negative binomial depending on my parameterization. This could be reduced to a Poisson model. Like, well, if this one is 0 or goes to infinity, I don't remember. It depends on how I how this likelihood is parameterized. And well, if I can estimate this rate here, and also this parameter here, I can put some structure in this one. So like this is the rate. So the log of the rate could be a fixed effect, or a fixed term, an intercept. I can have a time random effect, a delay random effect. So I can have these 2 effects. So this is called a random effects model, a mixed model, depends on the name you want. It depends where you see, but this is basically a mixed model. I have some random effects, I have some fixed effects, and I can put some time structure here, like, well, I can set an autoregressive term, a random walk. Here I'm using random walks, like what happened today depends on what happened yesterday, or today and yesterday and the day before, actually weeks. And this one, I can also say, I can also put an independent term or an autoregressive, a random walk. I can just set these guys. And well, and then I put some priors for the variance of those random effects for this parameter, for mu. So I put some priors, and then I have my full model. So, and then once I learn about the parameters, so I can have this posterior distribution here, but this is not what I actually want. I want to infer, or I want to estimate this triangle. So in order to estimate this triangle, I need to calculate what's called a predictive distribution. So all these N, T star, D star are the ends that belongs to that triangle. So I want to find the distribution of those guys given the observed one. So this is the gray area, and this is the blue area. So I want to find this distribution. Well, this distribution I can find if I include all my parameters. And if I know the posterior distribution of these parameters, I can include this. This is basically the likelihood, and this is the posterior. So I just integrate out the parameters. This is called the predictive distribution. And once I got the distribution for those guys, I can find, or I can estimate the distribution for the NTs. This is actually what I want. NTs are the column. So I estimate those guys, and then I sum this, and then I can get the whole time series here, which I could also use the same logics for forecast. So what I'm actually doing, it's a forecast, but I'm doing a forecast. I'm predicting what's happening now, which is called nowcast. So that's the term. And well, and how I do that, basically, I do it in a Monte Carlo way. So I got the distribution of my posterior distribution. I sample from it. For each sample, I sample from the likelihood. So I sample that triangle, calculate the NTs, and do it again, and do it again and again. This is basically a Monte Carlo. It's not even a Monte Carlo, Markov chain Monte Carlo. It's actually a Monte Carlo. And while this procedure is all written there in this paper, in Stats in Medicine, and well, it could be done under an MCMC. So if I'm doing an MCMC, this is relatively simple because I already have the posterior samples of my parameters. And well, and then this could be implemented in Nimble, JAGS, Stan, OpenBudge, whatever, or you can program actually. So you can do it, but MCMC can be computationally expensive, especially, well, if you run it in several regions, and this could be expensive. And I need to check if the posterior distribution converge. This is a very powerful tool, but well, it costs. And well, there is a method called INLA, which is integrated nested Laplace approximation, that find approximation for the posterior distribution, and I can sample from that approximation. So well, for those who are not familiar with INLA, there are some papers here. There's a website, INLA. And well, this is implemented in R, which is very convenient. So you can do very fast inference, and you can get the samples here, samples from the approximated posterior distribution, but that's good enough for me. Then I sample from those guys and do this algorithm here and calculate the triangle and have everything I need. So going back to the reuse data, when I do that, I calculate the posterior distribution. So I have the mu parameter, I have my over-dispersion parameter, the precision for time, precision for delay. I can calculate those guys. And I have those posterior distribution, I sample from them. Oh, actually I can see, so if I look at the random effects, I have the delay. So actually the delay component it's going down, but actually there is some significant significant values here for the first 4 weeks of delay. So well, something that's important. So it's there's some correlation there that, well, not correlation, but well, there's some importance here for the delay effect. And also the time is actually showing me the disease dynamics. And actually the disease here, it's going up. So, well, when I combine that, and I expected that this thing could be propagated for my forecast later. So And then when I look at the distribution for the notifications at week 15, I can derive the distribution. I can have samples from it. So basically I can have an histogram. We can have, well, a density or based on the histogram. This is actually what happened. So, well, that was a likely value to happen. So that was all right. And when I get this thing, I can, so based on my previous data and the delayed structure, I can learn about the delay. And this is actually what I nowcast. So this is what I observed. This is what actually happened. Well, not what, this is what I could predict that happened. So I could actually go beyond that and try to do some forecasts, but as you can see, the intervals are already big. I'm saying that, wow, it's going to have, well, it's going to be between, I don't know, 4,000 and 10,000 cases in a week. That's a massive interval, but wow, that's fair. My uncertainty is actually big. If I try to do forecasts, the intervals would be massive. So it's not worth to do it. This model is already in use in a surveillance system. And this is called InfoDengue, which is a system for monitoring cases of dengue, Zika, and Chikungunya. Dengue, Zika, and Chikungunya are 3 different diseases, 3 arbovirus, and we are monitoring these cases for the whole country. So you see why we need this to be fast, because we need to run a model for each municipality every week. So once we got the data, we need to run for all 5,500 municipalities at once. It's basically a night running, but we need to do it. And this is just one step for our surveillance system, because there are other things. We combine climate and social media. There are several things that we do it, not only the nowcast. So we need a model to be fast. And well, when we see if you enter in this website, info.dengue.mat.pr, you can see the system. And if your computer language is in English, it will be translated. So no worry, everything is Portuguese here because, well, my system here, when I did the print screen was in Portuguese, but that would be translated to English, hopefully. And this is the situation in Rio now. So this week, the number of cases, this is what we observe, this is what we estimate. It's above what we estimate is always above what we observe, but you see the number of cases here, it's nearly 0, but actually we are predicting 100 cases this week, which is reasonable. Which is a small number, but well, the dengue is around. And we also have some other measures saying, well, what's going on? So we have some color system, like, well, if it's green, yellow, orange, or red. So if it's red, we are in an epidemic situation. So now it's a good time for dengue. We don't have dengue now. And so basically the nowcast system, it's an approach based on this chain ladder model. Chain ladder is the name of that matrix. It's called a ladder. And this actually goes back to the 1980s and 1990s. So this model is not really new, but it's relatively new in the context of epidemics. So this model was used in actuarial sciences. They're trying to do some reserve claims and some money stuff. And in the epidemics, it's relatively new. So, and then we did some adaptations. So we need some spatial version of it. And there are some other relatively new papers working on this. So like they did a sliding window. Instead of using the whole time series, you just need a sliding window. You don't need to see the whole data set to do the nowcast. So there is this one that they did an app program to do it. It's called NOBS, N-O-B-S. And there is this other one that, well, they are our co-authors, and they decide to do a different thing, a different approach. They did a hierarchical framework doing an MCMC, which performs better, but is slower. Another thing we did was, well, now another disease called Chikungunya in Rio. So the red one is what we would see if we just take into account the extra week that we are. So basically, we would always underestimate the epidemic. And the gray one is the actual number of cases after, I don't know, after 3 months. Then we see, so he will have a large number of cases. And well, someone just had this idea. If you look at the Chikungunya related searches on Google, this is what happened. So it's really similar to actually the behavior of the curve. So the term nowcast actually came from the Google guys that they try to predict influenza systems based on the Google searches, which they did a really good job. It was a 2010 paper, and this is where they coined the term nowcast. They had some problems in the model, which is, well, I'm not talking about them, the problems here, but well, we could use this as a covariate in our model. I could learn, I could add this thing and try to learn and to see if this would improve my nowcast model. And how can I do that? Same model, I just add the covariate here. And this covariate here doesn't vary on, just varies on time. The D is fixed. So basically a time covariate, which is the searches for chikungunya related terms. I include those things here. And this was done by Miller and others while I'm here as well. And we just showed that the Google searches improve the nowcast. And we are trying to implement this now in our surveillance system because, well, it does improve, which is good. That's good news. We can just add some clever covariates and we can improve, or we can do a better job. This is a collaborate work between our team and the data science lab in Warwick, in UK. Now I'm going to change from arbovirus to COVID. And COVID deaths in Brazil, can we predict them? Can we, well, not predict, but can you correct? Can you correct the delay? Can you learn about the delay? And the answer is yes. Since we got all this, every week the data was saved in, well, the Minister of Health puts the data in a repository every Wednesday. Well, they do have some delays in there, but the week is important for us. So if they put any time in the same week, that's good. It works. And they had this repository, and then we saved this data set since June 2020. We save the whole data set every week, and we can build the delay. And well, and this is up to 2021. Well, middle 2021. This is the number of deaths due to COVID. If you look at this time series, we'd say, yay, the deaths are going down. Vaccines work. But we need to correct the delays. And when you do that, this is just to see how the model looks like. Since it's a time series, well, since it's a Monte Carlo approach, I have these trajectories. Well, I have 100 trajectories here, 100 time series. So actually, it was going down, but it seems to be, well, kind of getting some, so it's stabilized. It's not going down as we want to. So this is just, I'm just zooming in. Same place, so I have this time series, so 100 time series. If I got 1,000 time series, I got this idea, I can get the uncertainty. And well, with these 100 trajectories, I can get the intervals, 95%, 50% there. Why I'm showing this? Because, well, if you got each trajectory of this time series, if you think about this mechanistic models, the RT, if you want to calculate the RT, the effective reproductive number, and you got one time series, you can estimate this RT. And then if you do it 100 or 1,000 times, you're going to have 100, 1,000 RTs. And then you can get, and you can propagate the uncertainty. Because, well, since we have this uncertainty here, how can I propagate this uncertainty to my reproductive number? Well, that's easy. I just do it for each time series. And then the time series are there. We can just save it, calculate the reproductive number, and propagate the uncertainty. That can be done. Did we do it? No, we didn't. But well, this could be done. Well, this is done in dengue, but not for COVID. And then we look at the data, see, well, something going on here. And well, I can say, I can tell you what happened here in this time. This is the gamma variant. And during this time, also the vaccines arrived. When the vaccines arrived, the number of cases really go down, but the vaccines were not for everyone. And there are some group of people, the adults between 30 to 60, they were not vaccinated. And there is this, the number of cases started going up here. But while I'm looking at the aggregated data, I cannot differentiate that. And that's a problem because we have an age heterogeneity. We also have a spatial heterogeneity. When we talk about waves, how many waves did you have? So if you look at the Rios data, how many waves do you have? So 1, 2, 3, 4, 5, 6 waves. How many waves do you have in Amazonas? 3. So that is Omicron, Gamma, and the first one. And well, what happened in Rio Grande do Sul? I don't know. I don't know. How can you count the waves? I don't know. So the thing here is basically the dynamics of the disease is very heterogeneous. There is a high heterogeneity for the dynamics of disease. And this also happened for age, for different age groups. So like for the kids, well, we really don't see something. The number of kids are small. We knew that before. But when you see different age groups, wow, the 80s, 50 to 59, so something was going on. So you see there is a spike here, which is that there is an increase here, like which is a bit flat. This is what causes this movement here. And well, how can we how can we solve that? Well, basically we could do one model per region. This is already takes into account the spatial heterogeneity. And also I need to add the age structure. When you add the age structure, I'm basically adding a new subscript here. So, and then I can, for each time component for that matrix there, the same thing. So I do a time, I have time random effects that they differ among age groups. And also the delay structure may differ among age groups. Well, this somehow makes sense. Well, the dynamics was really clear that they differ among different age groups since they, for immunological reasons, but also the vaccine arrived in different speed and different age groups got the vaccines. The delay, well, the delay could not be different, but well, we have some hospitals which are essentially for kids, and they have a different structure to put the data into the system. So this makes some difference. I'm not saying that kids, that the delay for kids are smaller or bigger, they're just different. And then I'm taking this into account here. And well, and basically we do that, adding some matrix, some clever matrix here. And well, this is implemented in R. So we got a package. I have well, we have this co-author here, Rafael Lopes, which is really good guy for coding, and well, he's a good guy overall, but he's helping me to develop this package, and this package do the nowcast, the usual one, but also is doing the age-dependent nowcast. And when you do that, well, so I'm just taking an example here. There's this study here in Rio de Janeiro, end of 2021. So we have this data for different age groups. And then when you see the nowcast, well, basically this drop is really good because it was vaccine related. You see, like the kids that were not vaccinated didn't change much, but whereas the older groups, they really go down. Unluckily, this was just before Omicron, and then things goes up again. But well, it really did well. So that we showed that the number was going down. So, and then we could see for hospitalizations, hospitals, hospitalized cases, deaths for COVID, for just study, we can see they are very, and then we can see the nowcast performance. What happened when the variants arrived? So when this is the first one, the second one was the P2 in Rio. It's a Zeta variant. When the Zeta variant arrived, just end of 2020, we pick up that with the nowcast. We see that something was going on. When the Gamma arrived, we also showed that. And when the Delta arrived, we showed that. And also that, well, it's not going really high because when the Delta was about to arrive, we were really scared because the Delta variant didn't, well, it was a catastrophe in India. So we thought it could be here as well, but well, it wasn't. And it was captured in the nowcast as well. And yeah, so when you saw that, even though we were underestimating for here and here, we are actually getting the trend correctly. And so the nowcast was doing a good job. And well, actually this calls a lot of media attention. So in our team for Infogrip, we were all the time on TV saying, well, the things are not going well. And yeah, and a couple of weeks later, we saw, well, actually, those guys were right. And they actually, and then, well, then the Infogrip, it's on the media every week now, which is, well, not good because we are still there. So this is the overall nowcast, but we can see that for different age groups as well. And basically you can see what's going on for different age groups. Like, well, we were actually expecting something going up in a faster speed here for this age group, but well, it didn't confirm for others. Well, like this one is going down, which actually go down. So well, the nowcast did a good job actually, and well, I just showed that the nowcast works for COVID, and we do have two teams doing the real-time analysis for severe COVID cases, which is the Infogrip, which is the one in Fiocruz, and they have also this Observatório COVID BR, which is also doing the same sort of analysis using the open data. Infogrip uses data that the Minister of Health sent to us. Basically the same information, but different deals, or the Observatory has no deal to get the open data. And the Infogrip, we get this, we have a system there. When you click, when you can see the actual situation for each state, when you click on the state like this one, we have a probability of going up, going down, which is a very simple approach. It's basically a regression line that we fit here instead of calculating a reproductive number. And so yeah, so this is, we got the estimates, the uncertainty there. We have the trends, so we calculate these things, which is we get the age distribution here. So like, and this data here is 2022, first wave of Omicron, and this was when the second wave arrived. So we pick up that as well. So, and it was hitting the older groups, didn't change anything on kids, but the second wave of Omicron, something happened there. It was not a big one, but we got this wave there. Well, I'm just trying to summarize everything. I have no idea I'm on time because I forgot to turn on my chronometer.
You are.
I'm okay? Okay, good. Thanks. So the reporting delay is a well-known problem in disease surveillance. Basically, people tend to ignore the last weeks, and because, well, there is a delay, so they just ignore, but wow, we could learn about the delay and do something better. And that's what we are proposing. Well, not, there's some people proposing, and I'm not the only one. And we propose a fast approach to correct the delays, some extensions of it. This approach can be applied to any disease, really. So any disease that is compulsory or there is a notification system. So it can be done for dengue, malaria, chickenpox, or some other diseases that it's compulsory. In Brazil, there are 50 diseases that this is compulsory. Well, the model is robust enough to anticipate an outbreak. There is a star here because I need to do a proper analysis, which I didn't. But I just show some graphics and that's it. But I need to do a proper study here to show that the model is robust. And is already implemented in 2 early warning systems, InfoDengue and InfoGripe. InfoGripe is the sarin, it monitors the sarin notifications. InfoDengue monitors dengue, Zika, and Chikungunya in Brazil. Yeah, and that's it. For those that doesn't know Fiocruz, this is the castle of Fiocruz in Rio. Thank you very much.
Thank you, Leo. I think we have time for questions. Does anyone want to make any question? Just get a mic. Wait. Yeah, you can start. Ruth is making a question. Can you see the students, though? I guess.
Yeah, I see some of them. Yes, I can see. Yeah.
Okay. Hi. Thank you for the talk. It was very interesting. I have 2 questions. The first one is related to, if you have used the compartmental models, deterministic compartmental models, in order to compute parameters or to compare the estimations. And the other one is that if the nowcasting that you share us is robust, but in order to cut the time series. I mean, not since the beginning, since the middle of the time or since the quarter of the time, because the MCMC is an algorithm that takes a long time, and even more if you increase the time series. So, I mean that in order to reduce the time of computation, it's useful to reduce the time series.
Yeah, so 2 questions. So the first one is how to use this thinking compartmental models. So the simplest one is just take an estimate, a median or a mean for the time series, and then use it as a real time series and go on. And the other one, you have all the trajectories and try to fit the deterministic model to each trajectory. Then you're going to have 1,000 fits, and then you can propagate the estimates. You can get a mean for the fits and something like that. But the easiest one is basically to get mean time series or median time series and use it as a real one. The second one is the MCMC. So even in England, if you have the whole time series, it takes time. It is not as fast as I'd like to be. And when I reduce the time series, this is one paper published by people from Thailand, where they test how the sliding window, the size of the sliding window would be. And well, I could just use this sliding window, run MCMC, and still the MCMC would be a way slower than INLA. But well, the MCMC is a very powerful tool. And if my model is, if I have something else in my model, I may not be able to run it in INLA, and then I need to go to MCMC. So that's, both are very good. Both could be fine, but this strategy to reduce the time series work for both, for MCMC and for English as well. I'm not sure if I kind of, but that's really, really good to reduce the time series. So if I reduce the time series, I gain a lot because I reduce the number of parameters considerably and the things works.
Thank you.
Hi, thank you for the presentation. My name is Mateus. I have, it's not like a question, it's more a curiosity. I would like to know if you had noticed if this delayed time of notification is different between states or locations, and if there is some variable related to, I don't know, economical things or something like this that caused this delay to be bigger or smaller?
Yeah. So good. That's a good question. Yes, the delay varies a lot and varies for different reasons. So it varies in space. Like, well, if you go for rural areas, the delay is larger than urban areas for obvious reasons. Like, well, they may not have computer, so they cannot type the data, so they need to send the data somewhere. There is a place in Rio that they need to send all the not only dengue or all data they have, they need to send it to one place where the internet works, and they type it once a week. But this is in Rio. I'm not talking in Amazon forest or anything. So if you go to Amazon forest, then you have this, they got all this paperwork, they put in a boat, go to somewhere, and then they need to type. So there is some infrastructure problem that causes bigger delay. But also, if you think about time, when you are in the middle of epidemics, you also have a bigger delay. Why? Well, it varies, but the people who actually type the data into the system are the health workers. And well, you need to, sometimes a person needs to choose between typing data into the system or treat patients. Well, that's an obvious choice. So obviously, they treat the patients, then the delay increase. But when this happens, sometimes the mayor or the health secretary, they hire people to type. So the type is faster. So it varies a lot. And also, if you are facing COVID epidemics, then the dengue data would be a bigger delay. So there are a lot of stuff going on that it's hard to predict, hard to anticipate, but they vary. If that answers your question, I hope so.
Go ahead. There's another question from the same guy.
I would like to know if, because you are working with this during the pandemics and everything, so how was the relationship with the governments, with the observatory? Like, they were receptive with the suggestions of what to do and these kind of things, or they were not?
That's a tricky question, right? Like, well, we did send it to the health secretaries, but we used to do that before, even before the pandemics. Since we find something, but we already send all the reports automatically to every health secretary, all the 27 ones for each federal units. Some places, they actually include our reports into their decision process system. Basically, they get meetings, they look at our reports and decide whatever to do. If they actually do something, I don't know, but we just send to them. The Minister of Health, we have this deal as well, because they send us the data and then we send them back the reports. And we have a very good relationship with the technical team of the Minister of Health. Basically, we analyze the data. We do a lot of, we still keep doing this. We have a good relationship between the technical teams, the technical team for influenza and respiratory diseases. The same thing apply for, you specifically asked for the COVID, and we did send and they got the data, and what they did with that, it's unclear to us. We also do the same stuff with dengue. Same thing, we got when we are showing that the place is actually facing an epidemic, we send an email. Well, we actually send it every week, but when something is going odd, we send another email saying, well, something's going on there. Could you say if could you confirm it or something like that? So we have this relatively close relationship between the decision makers, but not so close but we just send them the information and then they do whatever they want. But some of them include our reports into their decision-making process. But this is as far as I know.
Any other questions? Yeah, one more question here.
Hi, Professor. I have just two quick questions. It wasn't clear to me which data set you said you were using. You were using the one from Observatório Covid, the one that they gather the data from the government, or did the government feed to you directly this data with the updated time series and whatnot? That's both. The first question. The second question is about I noticed that a lot of the simulations ran with a little higher numbers than the actual data afterwards. And I wanted to know if there's any specific reason for that, if for example, the delay was weighing too much or something like that. And yeah, those are the two questions I had.
Cool, yeah. So, well, the main source of the COVID data, it's a system called CVEP, which is this system. We got the same, this is a system where all the cases are registered. And this data set, there is an open version of it, which is public in Open Data Source website. And then the observatory just downloaded and organized it. The InfoGrip got the same data set directly from the Minister of Health, same data, but then we analyze it. So the same data set in two different versions, and the Observatorio, they gather the data, save it, and have these snapshots for the data sets. The InfoGrip, we got the whole data set and run it once. And then, so same data, but the two teams do a different analysis of it. The second question was, what was the second question again? Sorry.
If you have any specific, or if you have any idea why the simulations were always a little higher than the actual number of
cool.
cases.
Yeah, cool. So whenever we see something strange going on, we try to fix it. So this age-dependent nowcast, it came out because we were actually overestimating a lot. And we realized that something was really strange because we are not taking into account the age structure. When we found out that, we fixed the age structure. We add an age component, but we didn't add an age dependence for delay. And then we decide, when we run it, we keep seeing that the kids' estimates were always going up. And then we actually did some interviews saying, well, the kids are going up as well, but it was basically delayed. The delay structure was different. And then when we fix it, the thing was not odd anymore, but well, we didn't know that before. And then we stopped saying alarms for kids. But and when something odd appear, we just try to investigate and try to understand why. Well, basically how science works, really. We try to understand what's going on and try to fix it, and yeah, that's it. So yeah, so basically your question is basically what we keep doing the whole the whole pandemic. Something go strange. Why this thing's going strange? And then we try to see, oh, that's why. So just go there and fix the model, improve the model, and keeps going on.
That's really cool. And I have a follow-up question. Are you informing your models with like the age structure of the population using like the IBGE census or something?
Yes, that's a very good question and tricky one as well. We do, because we calculate the incidence. We're not adding this into the model because we estimate only the number of cases, and then we calculate the estimates for incidence. But when we calculate the incidence, we need to divide by that population. And that population is not very good because we are doing projections from the 2010 census, and something, we know it's not good, but well, could be better.
Hello, Leo. Thank you very much for your presentation. I think you just more or less answered the question I was going to make. I was going to ask if I understood right, you created the algorithm for nowcasting, and then you refined it, adding the age categories. I was going to ask, why did you choose this category and not other category?
Well, age was basically during the pandemics, when you think about the vaccine, what was the most important priority variable for define the vaccine component, the vaccine, who is going to take the vaccine? It was age. And age and the vaccine would affect the hospitalized cases and deaths. So basically, I need to take into account the age. Could I choose others? Yes, I could. But well, age seems to this contest to be the most kind of, the most important one. Probably there are others, but we thought that age would be something really important, and it would change the model, it would improve the model a lot. So we spend our time to trying to fix it, and it works. But are there others? Probably.
Thank you. And another question, at the end you said the model was robust. What does that mean, more precisely?
That's why there's a star there. It's like, well, it's good enough for me. That's what I mean by robust. Like, well, I mean, all the time there is a new variant arriving or something different going on, the model captured that. So that's what I try to mean by robust. Like, well, for instance, like all the variants, when the variants arrived, we picked that up. Also, when there is the influenza weird epidemics here that started here in Rio in December, November last year, which is really odd. We got that. We saw that before, and then we say, well, something really strange is going on. I don't think it's a new variant. Something strange because, well, the behavior of the data is different, but well, something is going on. Then a couple of weeks later, just found out it was an influenza case. Well, and then it spread around the country and goes around, and then, so it's robust in a sense that, well, we anticipate something different when something different occurs. But I need to improve that. I need to remove that star to say if something is really robust.
Thank you very much.
Hello, my name is Juan. I think that my question is more because I'm not Brazilian and I'm not sure how it works here, but I see, and please correct me if I am wrong, but I see that when the vaccination starts, the cases increase, and I am curious, do you think that this is because the delay or because the...
No, yeah, I can tell you what happened. There is that thing that when the vaccine occurs, the curve starts going up. That was really weird. I agree with you. We shouldn't. But when we separate the age categories and we see who is going up, are those that are not vaccinated yet, are those between 20 to 50 or 20 to 59-year-old. Those are the guys that start going up. And why was that? Because, well, since the old ones, I'm not saying the old ones, so since people over 60 start getting vaccines, the people who are taking care of them start to relax. So now I can go out, and then I think I can be more relaxed, and this behavior probably get them infected, and lots of people infected. Some of them got hospitalized and go to death in those age group because they were not vaccinated yet. And this is what I'm speculating, and actually what the data suggests. Well, the data is not suggesting people are going out because they're relaxing, but those age groups increased, not the old ones. The old ones were going down, proving that vaccines work. I think Flavia could explain this better. we're just trying to publish a paper on that.
Yeah, but
hopefully it finished.
Finished
at some point.
Do you have any compliment? No. There's one more question here.
It's me? Oh, okay. Hello, my name is Denise. I had a couple of questions, also because I'm not Brazilian. How's the reporting system for dengue, Zika, and Chikungunya? Like, is it like laboratory test? Is it like doctors should see the person and say, oh, you're this or that? Mostly because they have like similar symptoms and all that.
Oh, that's a wonderful question. And I should have a slide talking about dengue before, because I thought, well, everyone knows dengue. So I'm just, no, actually, dengue in Brazil, it's, well, how the dengue system, how the dengue notification works. Those data that I'm using are the suspected cases. So if a doctor suspects it's dengue, he must notify it as dengue. And maybe it will be tested. It's not compulsory to test. But we are, since it's a surveillance system, we are trying to get the earlier information we got. So we just look at the suspected cases. Could they misdiagnose? They get a wrong diagnosis? Yes, they could, and probably they will. Like if the person has all those symptoms, and the doctor, especially if it's light symptoms, if the doctor thinks it's dengue, it's maybe chikungunya, it may be dengue, I don't know. It may be Zika, maybe other thing, I don't know. Like, but the thing is, if someone suspects, basically a doctor, if a doctor suspects it's dengue or chikungunya or something, we count it. And then since we counted, we are forecasting the suspected cases, or not forecasting, now casting the suspected cases. This data will eventually be lab confirmed. Not all of them, but some of them will be confirmed, and we could check what actually happened. But in the surveillance system, we are just using the suspect cases.
Oh, okay.
I'm not sure if I...
Yes, exactly. Yeah, I was thinking about Zika and like how people were counting Zika as dengue before and all that. And going to the nowcasting of COVID cases, you said that they were like, you were like getting errors when there was a new variant, right? Like those color curves. Is there a way using that, like, hey, nowcasting is failing to estimate when a new variant is getting into the population and how it is spreading?
No, actually not failing. That's the thing. It's actually getting right. It was failing in the sense that was not estimated as high as it should be, but the trend change. The trend changes. Like, well, something start changing, messing the system, and the number of cases start going up, and then we pick up that. Not as much as we should, but this varies on the how severe was that variant. Like the Omicron was impossible. It happened like in a week, everyone got infected, and no system can actually pick up that.
Oh, okay.
I should put it there here. I forgot. But Omicron, we didn't. We basically saw that Omicron happened 2 weeks after it actually happened, which is useless. But the Omicron, no, especially the first version of Omicron, was really fast in Rio. It was crazy. Probably crazy everywhere. But the second one, we have a second wave in June this year. That one, we actually got it right.
Oh, okay. Thank you.
There is one more question in the back.
Hello, my name is Cristiana. Thank you for the presentation. It was really nice. I just wanted to ask you, because you said the nowcast solved the problem of the delay when you were dealing with the present time. How can we use this updated information to predict for the future?
Okay, cool. That's a very good question. The same method works for prediction. So we could do forecast just in our package. Basically, we have a number of weeks we want to do it ahead. What is the problem? The uncertainty. The uncertainty may be too big. And if we don't have any variable to fix it, the uncertainty would just be massive. Like, well, I would say that in 3 weeks' time, we're going to be between 0 and 100,000 dengue cases. And well, but that's the thing. It's the trick is uncertainty, how to reduce uncertainty. So if we use like dengue searches, or if you use some covariate that help us to reduce that uncertainty, we can do forecast. But the model is basically, the way it is, it's able to do forecast.
Thank you.
There is one more here now. I don't know if you can see the students, but they are around.
Yeah, I can see them.
Hello, thanks for the presentation. I'm curious about how long does a simulation take to run? Because could it be like an extra delay factor or something when dealing with nowcasting?
It could, but it's really fast. It's like about 1 minute. So, but when we got the data for the whole country, we do for all, I don't know how many macro regions we have here in Brazil. I think 500, 400. I don't know. There is a 300 macro regions. So we run the model for each macro region. This is for the SARI case. We do for each macro region and then we do some other analysis. It's basically an overnight run. We just put the machine to run, and it's overnight. We put it to run at, I don't know, midnight, and 6 a.m. we got all the results, and it's all on the website already. For the dengue one, we do for 5,500 municipalities. This one takes longer, but it's 1 or 2 days running. I think it's just 1 day, because well, most of the cities have a lot of zeros, and we don't run. But so it's one. So since this is the reason that we choose to work. Well, this is not the only reason, but we choose to work on weekly based data. So we don't have a delay to report. If that's what we want, right?
Okay, thank you.
Any other question? There is one more. People here like to make questions now.
Yeah, that's really good. I'm really happy for that. Yeah.
Hi, my name is Elaine. Thanks, Leo, for the lecture. It was very nice. And it's more like a curiosity, because at the end of your presentation, you said that for any disease that we have enough data, any disease like notified ones, you can apply this kind of approach. And
Yeah.
I would like to know if you have plans to do it for other diseases. Just curiosity.
Yeah, no, yeah, we are doing for malaria now, and well, but the malaria one is basically a methodological paper. It's not an early warning system yet. Well, I don't know if it's going to be eventually, but and now since we are looking the SARI ones, we are trying to look at different respiratory virus there inside the SARI. We have the VSR, influenza. We are trying to do the nowcast for those guys because we have several respiratory virus disease there. We are trying to separate these and, for instance, look at the VSR, is syncytial respiratory virus for kids, which is an important one. And then we're trying to do that, but still kind of anti-work, like small steps.
Thanks.
More questions? I think we did many. That's good.
Yeah, very good. Yeah, very good.
But of course you can enter in contact with Leo, I guess, right, Leo?
Sure.
And make questions if you want. In the future, I would like to say thank you very much, Leo, for accepting my invitation. I'm the person that is all the time asking things for Leo, and he always accepts.
No, that's very good.
He always accepts. That's good. And thank you so much, and have a nice day.
All right, thank you. Bye-bye.